it seems like a long time since we've all gone together in the same room. And Peter was counting how many people had ties in the room to sort of see that we can wear ties. And this does qualify as a tie. It's a bolo tie. So.
David Bain.
Yeah. David, congratulations on that tie. Nice to see that. Well, we're all very excited to have Cheryl Lee here. For those of us in the GU surgeons, you know, Cheryl's been a star there. And I think it was like 2 years ago, Cheryl had me out as visiting professor, and we went to, they have a little game in Ohio called football there. And we went to the Ohio State football game and the horseshoe. And we had a wonderful time. We're sitting there all of a sudden, like after like the first or second quarter in the huge, you know, Jumbotron, all of a sudden, Cheryl Lee's there, welcoming everybody to the football game. So it was very exciting seeing that. But she has an amazing program in Columbus, and she has been an inspiration for a lot of my pleasure books that I read that we share back and forth. But we're very excited to have you here. And I'm going to hand it over to Peter here for a second. Yeah.
I'll say more about Cheryl tonight, but I understand you're going out to play pickleball today.
Yeah.
Pickleball to me is like a virus. I'm the last person who doesn't play pickleball.
I have to say, I've never played pickleball
It's probably
before,
good.
but I wanted to do it because, you know, everybody's doing it.
You guys better be nice to Cheryl, guys.
I think who's behind it. I mean,
Who's behind it?
I think pickleball, it's amazing. This is lots of the population quicker than COVID. So I mean, it's a little bit, you know, those science fiction movies from the 1950s, but something goes wrong, and then all of a sudden, you know, the whole world's taken over by outside forces. It could be pickleball, but it won't be me. I do have a small gift for you. I can wear this today. It's
Oh,
a
great.
jacket.
Thank
Now,
you. Thank you.
This is, I'm going to get another jacket because I decided one of my last Access chairs to get new jackets. And because I'm so tired of the Patagonia, North Face. So now we're going to get a real person's jacket that comes from cool. So we'll get this out of your
Thank you.
So, you know, there are many people in this room who are interested in getting unrepresented segments of the population into our trials. And I remember we were at an NIH meeting in Madison, Wisconsin, and they were asking the people in Madison, how come you don't have any African Americans or Hispanics? You know, Marshall in San Francisco was able to enroll all these people. And I think Steve Nakata says, hey, have you walked outside here? I'm the only Asian here. Everyone else is white, you know, so there's not the diversity that you have in San Francisco. But it is a big deal about trying to get a diverse population for these clinical trials. So for the first of many talks here, Cheryl's going to talk about these issues, and we're so excited to have her here. And what is the Ohio State team's name? The football team.
It's the Buckeyes.
Okay, the Buckeyes. That's right.
I won't yell OH.
Yeah.
I won't get any response here. Thank you so much, Marshall. It's so wonderful. You wouldn't actually remember, but I think you were out about 5 years ago.
Was it 5 years
It was
ago?
pre-COVID, so that we kind of we've lost a couple of years.
Yeah.
Well, I want to thank Marshall. I want to thank Peter for inviting me and for having the opportunity to think about this issue now that it's gone, but to think about this issue. I've been involved in some work with the NCI over the last 6 months in a project at Ohio State. We don't have much data on that yet, but I want to talk a little bit about it. And then at the end, I'll tell you more about what that project entails. But first, I want to say thank you to the residents and your sub-Is. Yesterday, we had a wonderful day, a wonderful afternoon where we talked and reflected about personal missions and the importance of that in the context of leadership. And we had an exercise where we pretended that the residents were the program director, and the chair had asked them to actually do some programming that was very specific to the personal missions of the various residents. We did it across the education mission up on the up here in the left, research, clinical, and service. And the residents worked under pressure in 25 minutes. They were able to develop some really novel and innovative programs, all specific to their own personal missions within their group. It's fantastic. We saved these for you because really there was some great work. The winner of our competition was Group 4 with the youth. This is blocking it, so you can't see it, but the name of the program is the UCSF Service Project, UYOUCSEESF, which really gets providers out of the hospital into the community and providing care to patients where they are. So I just want to say thanks to the residents for going through that exercise. It's one that really allows people to work together, to collaborate, to present, to be creative, and you all really rose to the occasion. So thank you. Now, I have no disclosures. Are we able to, oh, is that the Zoom? Is that why that's on the screen? I want to also say welcome from Columbus. This is the Ohio State University. We have our undergraduate campus that's pretty close to the medical campus. And this is the undergraduate campus here. We're over 150 years old, a land grant institution, and we have 7 health sciences colleges on the campus. So it's really a wonderful space. This is the medical campus here on the upper right, and you'll see I'm going to pick this up because it may be a little bit easier. You'll see the main hospital here, the James Cancer Hospital. We have a couple of hospitals that aren't in this area, and then there's a heart hospital tucked in here. On the lower left, this is the James Cancer Hospital from the various another view. And then this is our new inpatient tower that will be opening in 2026. So really excited about a lot of growth and development, and can't wait to welcome folks from UCSF to our campus. Dr. Hampson is coming as a visiting professor in the fall. Our residents selected her, so we're really excited to have her visit. So why are we talking about this issue of underrepresentation in clinical trials? I mean, I think over the last 2 to 3 years, there's been so much attention to so many areas that relate to medical and health disparities and health equity. When I think about health equity, I'm really thinking about, as a field, how we're going to allow our citizens, the folks in our region, in our catchment area, those that we treat, to achieve their full potential. You all have seen all of these kind of infographics that contrast equity and equality, with equity really being our process of giving people what they need so that they can have the access that they need. And in this infographic, they're having, kind of the access to the door to get into the hospital. But in truth, when we're talking about health equity, we're really thinking about improving health. We're thinking about increasing the quality of the care that we deliver, but we also want to reduce disparities. Part of the issue with disparities is that patients don't always have the same access. And it's not just to the front door, but it's to other services that are going to improve health, for example, in clinical trials. So this concept of improving representation, I'm going to describe, is important for a number of reasons, but it is also a way of access to good care and to high quality care. When we talk about populations that are underrepresented, the NIH describes multiple groups, and historically we have historically underrepresented folks are often Black and Brown people, those with a lower socioeconomic status, those who are under or uninsured, and also those who are immigrants, asylum seekers, refugees, and in San Francisco, I imagine, like in Columbus, you have a fair immigrant population, and many have low English proficiency, making it even more challenging to kind of get into the health system, let alone onto a clinical trial. Also individuals with disabilities, the very young and the very old, and LGBTQ+. Sorry, that's blocking that, but I'll navigate there for you.
We're working on it.
Oh, okay, great. So we're seeing that some patients and populations are underrepresented. Why is that a problem? What is the benefit of participating in a clinical trial? I think we all know this, but cancers that have been actively executing clinical trials have a greater and more accelerated rate of improved clinical outcomes and improved survival. Now, this is true in the cancer space for their disease, for their organ site. So it makes a difference when your organ site is actually executing clinical trials. The other thing we know is that participants in clinical trials have better health outcomes than non-participants. There's many things that we could speculate about that, but obviously when you're on a clinical trial, you get very close clinical attention. You're followed closely, you're tested very carefully, and many believe that helps to contribute to better outcomes. In addition, and we talk about the fact that overall in our country, there's a very small number, less than 10%, 8% or something like that, that are actually participating in clinical trials. But for adult cancer patients, when more than half of them will actually participate, if you ask them. If you ask them, more than half will actually participate. So part of what we need to remember to do is ask people, which is not always easy in a busy clinic, especially if you don't have the resources to help with screening and that kind of thing. When we think about the benefits of being on a clinical trial, how does that then change practice? We know with large clinical trials, phase 3 studies, for example, we can see paradigm shifting and practice changing clinical trials. So if populations are underrepresented or almost absent from those trials, it can be very difficult to generalize the findings to those populations. It's also important to recognize that with clinical trials, those trials are turning into FDA-approved therapeutics that will be delivered broadly. So again, if populations are absent from those trials, we really don't know how well those drugs are working or how well those agents are working in those individuals. This is just some data that came from the American Association for Cancer Research Cancer Disparities Progress report that they put out just recently, earlier this year, showing that the FDA approved 81 oral anti-cancer chemotherapeutics based on data from 142 clinical trials. Only 52% of those trials even reported race and ethnicity. So you can imagine that would be very difficult then to track and follow who's actually participating in those studies. And you'll see in the graph, the very small number of Black and Hispanic patients within those trials that did report race and ethnicity. So with 2.3% Hispanic and 2.5% Black, and other is wider, and our other is getting bigger these days because people are self-reporting and thinking about their background, or they would rather not report. So that other is becoming more heterogeneous. But I think it is clear to see that in these important trials that do lead to practice changes, new drugs that will impact our populations, that we're not representing our full population. The other important piece to think about are the secondary correlates that flow from clinical trials. And this is just, again, some data from that report suggesting that 77% of the tumor samples in the TCGA are actually from white populations. So again, a more homogeneous group. So a lot of these tissue samples are correlative receipts from large clinical trials. So if the trial is underrepresented, then the tissue banks are underrepresented. So we have to keep that in mind, because it's these tissue banks that are going to lead to precision medicine, hypothesis generation, and future trials and studies, future diagnostics, biomarkers. So all of these are flowing ultimately from the original population. When we think about health disparities, I think it is fair to say that we are making some progress in several areas. Some, I won't show all of it, some related to screening, some related to addressing issues of social determinants. But this is some data just showing that even in the comparison between Black and white populations over time, that the gap, the mortality gap as it relates to cancer disparities is actually shrinking a bit. It's not even, but I show this to underscore the fact that there are actionable things that can be done. It's not that these disparities exist and we have no way to narrow that gap. And there's some wonderful examples over the last year or a couple of years with colorectal cancer and improving screening rates, and those rates leading to reduction in mortality. So we do know that there are actionable issues that we can address. But I think the issue of the financial toxicity and other social determinants that impact patients clearly impact their ability to participate in clinical trials. In Ohio, Appalachia runs through part of our state. We have a large rural population. And in fact, 2/3 of rural cancer survivors from Appalachia face financial distress. We also know that patients in rural settings will have a 17% higher mortality rate overall across all cancers. So we think about some of the social determinants that are impacting these folks, that impact their transportation, impact their ability to participate willingly in trials. Now, telehealth actually has been a blessing for us in this regard, but as we know, with the end of the emergency, the public emergency, those, support for those and reimbursement for those are going to be dwindling over the next couple of years, and it's going to really impact patients in rural areas. The other interesting fact about financial toxicity is that patients will develop coping behaviors. And in fact, Black patients are twice as likely to develop these kinds of coping financial strategies, such as not taking medication. So one other benefit from being part of a clinical trial often is that you're able to get the medication and get the therapy fully, obviously, unless there's adverse events or toxicity. But we should be thinking that the clinical trial actually may be a way around some of the social determinants that, that many patients face. There certainly are activities that are ongoing right now that I would say have been developed over the last couple years that are real, that's real evidence of collaboration across the nation and also with some support from the federal government. The NIH has the All of Us project, which is a pretty ambitious effort to have 1 million people donate tissue specimen. And already there's been 100,000 people who have done so. and 50% are from underrepresented groups. So these kinds of efforts actually, I think, are going to be ways that the in scientists across the country and across the world likely will be able to share in these kinds of mass collaborative kind of tissue banks. And the AACR has a Genie project, which is a collaboration across 19 institutions to sequence tissue and then to share the results publicly. And there's a real interest in enriching these repositories with patients from underrepresented populations. So I would say that there's activity at the federal level and at the level of our large research organizations to try to make a difference and change our access to biologic samples across the spectrum of populations. Another piece of evidence of that is the National Academy 2022 Consensus Report. And this is important because when the National Academy gets together and really studies an issue, a lot of funds often flow from that. I would say that this is what has already started, but I think we're going to see that ramp up now that this report is out. But the report really looked at multiple areas and aspects of clinical trial representation and what the impact of that underrepresentation is for many groups. An obvious one that I already mentioned is that when populations are underrepresented, it's hard to generalize the research that's coming from that work. The other important issue is that there is a real cost to it. We know that people who are participating in clinical trials have better health outcomes. So if you think about the opportunity cost lost there, this group has done some calculations and says we're losing billions of dollars from loss of life, loss of productivity, loss of people at work, et cetera. So there are opportunity costs there. There's the issue of hindering innovation and new discoveries that we might find in various populations. And then there's a real issue that relates to clinical trial failures as a result of low accrual. So many trials close because of low accrual. If you can augment multiple populations into your trials, then that can hopefully reduce that rate of early closure. And then, of course, we in this country often struggle with issues around trust and mistrust by some populations of the medical establishment and also of clinical research, including clinical trials. So as people are more or remain disenfranchised from clinical research, it's unlikely that that's going to get much better. And I think there are many populations over time recognize the benefits of clinical trials and want to participate. And then, of course, there is the risk that we might continue to have persistent health disparities if we're not accounting for the issues of disparities within our research. So for many reasons, this group is recommending a whole series of actions, like I said, hopefully that the federal government will undertake and fund so that we'll see a greater study and research around ways to improve representation in trials. And then lastly, I'll mention a law that was passed just a couple years ago. It's called the Henrietta Lacks Enhancing Cancer Research Act of 2019, although it was actually signed in 2021. And Henrietta Lacks is the woman where the HeLa cells came from. She had cervical cancer at a very early age and was taken care of at Hopkins in Baltimore. And those cells were used without her consent in research, and those cells were immortalized. And of course, if anybody's worked in a lab as a student or a fellow or any other time, probably have done some work with these cells. So the cells themselves have been transformational for biomedical science. Again, but not really with her consent. But So this law, and it's memorializing her name, is really being hopefully being used to break down barriers for people to participate in clinical trials. And the focus is on federally funded clinical trials. So all of our cooperative group studies, for example. So I would say over the past couple of years, there have been a lot of efforts to really, I would say, take actionable steps by the federal government and other large agencies and organizations to improve our representation on trials. You know, when I think about trials in urology, I'm very excited about the number of trials that are being performed in our field. It's just, you know, it's growing. They're more collaborative. I would say that we've had a lot of movement, particularly in the oncology space, but also in female pelvic medicine and reconstructive surgery and stone disease. So, I just feel like we're, with the groups that are formed, many people are being willing to participate in multi-center studies. So it's all very positive. I think we still do struggle, though, with enriching populations that are reflective of our catchment areas. Marshall, you were just talking about the fact that you've had a lot of great success with diversity in your clinical trial populations, but it hasn't been always very simple. We have a pretty diverse area in Columbus, so we generally are able to closely match or be very close to our match in our comprehensive cancer center. For benign disease, I don't think we do as well. I'm going to be honest there. And there's less ways to track that. So I think as I was looking and thinking about this, I started thinking about the PROTECT trial. Now, some of the 15-year data came out recently, and this is a remarkable and Herculean effort, a study, you know, done in Europe, looking at active monitoring, prostatectomy, and radiotherapy for patients who had prostate cancer. They were identified after PSA screening. And after 15 years, and their main endpoint is seen here, death from prostate cancer. We would see one that the actual percentage of patients who died overall was pretty low. It's pretty low, and really not very different between the groups. Now, there's a number of other secondary outcomes that was part of this study, some related to the development of metastatic disease, use of androgen deprivation therapy, clinical progression, and some of these other more negative cancer outcomes were seen to a higher degree in the patients who did not receive treatment. But I bring this up because it was a very remarkable and Herculean effort, and could really impact the way we manage prostate cancer patients. Now, in truth, much has changed in the management of prostate cancer since the PROTECT trial was initiated. So the landscape is a bit different, and we're monitoring people differently. We're diagnosing people differently. But I say this because these are some pretty major conclusions, which are fair based on the trial. But when you look at this study, I could not even find the race ethnicity data in the article that came out recently. It must be in the supplementary data somewhere, but I did not see it. So it's an example of a study that could have a substantial impact, and did have impact. And over time, like I said, probably the impact may be lessening, but it's still teaching us a lot about the disease and the population. But we didn't capture race and ethnicity data. Now, the population may have been more homogeneous, but even in this 15-year data, it would be nice to know how patients are doing 15 years out, given the disparities that we know exist in prostate cancer, particularly for African-American men. The group at Northwestern has been looking at underrepresentation in clinical and translational research because of some of the issues I was talking about before, that biomarkers flow from secondary correlative tissues. And if, for example, a lot of those are flowing from the prior pivot trial in prostate cancer. And the problem is if you have very few high-risk patients in your pool that you're using to develop biomarkers and other issues that will be important for practice or other diagnostic tools, you're losing your representation of some of your high-risk patients. So that gets to be a problem when we think about diagnostics and also nomograms or other factors. Are our highest risk patients actually represented well in those groups? And one of the approaches that I think we can all learn from and that they're working on at Northwestern is to be very active on a multi-level space, looking at the system issues that contribute, some that relate to funding for strategies to improve our ability to identify patients, well, to actually enrich. So not just identify patients, but actually go out and seek patients to enrich trials enrich the accrual of those patients into some of these larger trials. And at the same time, reach out to populations and to patients with greater education and also to communities to get greater buy-in and greater understanding for the work. There's in another field, in FPMRS, there's always a lot of discussion about stress urinary incontinence and some of the racial disparities that are experienced there, especially for Hispanic women. And unfortunately, many of the trials, and I hope I don't get a tomato thrown at me, but from what I understand in my reading of the literature, that many of the trials actually are far underrepresented in Hispanic women, which would be a higher risk group for incontinence. This group, actually, this is a single institution study, so this is, I'll say that there, but they looked at their populations from their own group from something like 2013 to 2019, and specifically enriched for what would be considered historically underrepresented populations, Black, Hispanic, and then combinations or mixed or did not report in the other category. And so in this study, there's quite a bit of Hispanic women, and they make up the largest cohort. And when you look at the data, I mean, it begins to look a little bit different, in terms of seeking treatment, seeking counseling. Actually, the biggest disparities are with Black women and non-Black women. So it's interesting, as you enrich your pool, we may actually have to rethink some of who we thought was the highest risk group. And in this study, Black women were less likely to consult with a specialist and also less likely to actually receive active treatment. This is an older study, but a major study in the area of incontinence. And I just bring it up because it's another practice-changing type of study that was comparing transobturator and midurethral slings, which in the end, I think it was similar, but still an important study. And when we look at the demographics of the study here, again, thinking about some of the highest risk people, I feel like there's an overrepresentation of non-Hispanic white women and an underrepresented group of the higher risk populations of women, Hispanic and Black, and then some appear to be absent. Some appear to almost be absent, Asians and others. As a field, I know that we have, I would say, a sharpened focus, particularly at the level of the AUA, in trying to really organize collaborations to reduce these kinds of disparities within research. And the AUA and the chief officer for diversity, equity, inclusion, Dr. Larissa Bressler, are working to actually cement some of these types of clinical collaborations that can work together to actually create pilots and models in areas of our specialty that others can later adopt and implement. But I think there are some obvious things that we can do to increase representation. Even before all of those pilots are done, one, we can talk about it more. We can just talk about it, this issue of clinical representation in clinical trials, patient representation. This is just the planning committee for a symposium that we held at the AUA this past spring to talk about challenges in urologic research and how we could use the tools we have to improve health disparities. Dr. Washington participated and was outstanding, so thank you for joining that planning committee. But we had, I would say, a very robust discussion around collaborations and some of the actionable steps that we can all take, and not just in clinical trials, but in translational research, in health services research, thinking about even statistical modeling that we can do to try to gain more information from the populations that we do have access to. So I do think this is one of the things we can do as urologists. One, talk about the issues and work together. We can also talk about it with some of our colleagues. This was a panel we had at ASCO GU again this spring to talk about some health equity issues, but issues around research came up in addition. So having these conversations in our own sphere at the AUA, having these conversations at GU ASCO and in other forums at AACR, I think gives us really the room and the freedom to be able to brainstorm and to be able to pilot things. So there's various initiatives out there. I also think some of the research that's happening now, and many people some of our more junior people in the field are doing some really interesting work. This publication, which came out not too long ago, within the past 6 months or so, was looking at the implication of underrepresentation in clinical trials as it relates to our guidelines. So they looked at the clinical trials that were used to guide the practice of female pelvic medicine reconstructive surgery with SUFU and the AUA combined together, and said, what do those trials look like? How are they represented? One thing that was important to note was that about 2/3 of the trials, and they looked through about 90 plus trials, 52 were actually evaluable and able to be studied, but 2/3 came from outside of the US. And when you look at just the reporting of race and ethnic data, there was zero trials reported racial and ethnic data. In the US, it was just over half. So I would say one thing that we can do as urologists, as we're embarking on clinical research and trials, is we need to capture race and ethnicity data. It's not something that has been a priority in the past, but journals and funding organizations are going to be requiring this. The other observation from this study is, when you look across the racial and ethnic representation in these groups of 52 trials that are guiding practice in an area where, again, they're high-risk populations, non-Hispanic white women are very overrepresented. And those groups, again, that are felt to be high risk are underrepresented or absent. So I think we really have to intentionally work to enrich trials. And once we're capturing that data too regularly, I think it's more apparent and obvious what patients are not participating. Here at UCSF, you all have done a great job of engaging the community and actually thinking about the issues around the needs of the communities, the research priorities that the community has, and what they would like to engage in terms of research. For those who work in NCI designated comprehensive cancer centers, this is what the NCI wants us to do. They want us to engage the community. They want us to learn what priorities the community has, and they want us to collaborate with them. And they want to see translational and clinical research flow from those types of collaborations. So the concept of engaging the community, either through community advisory boards, through other activities or groups in the community, and understanding what they need or want is an important one. And really encouraging and funding and supporting community engagement and involvement in research. I think what our experience has been in our community outreach and engagement group is that when you have the relationships and they're longitudinal, that the community advisory boards and the leaders in the community will really facilitate the efforts at accrual for clinical research and encourage community members to participate. So I do think that's another thing that we can do as urologists. I also want to make note of the eligibility criteria that many of us have used when we've created protocols, and that as we develop new trials. Many of these flow from the NCI and from cooperative groups. What we know is that some of these criteria really have been a barrier for patient participation. And I think we've all been there trying to put a patient on a trial, and there's something very small and a piece of minutia almost, and that will not allow them to get on the trial. Well, the NCI has worked together with a collaborative group, a multidisciplinary group, and worked with ASCO over the last few years to actually relax some of the eligibility criteria for clinical trials. And these are some of the areas that have been relaxed. The requirement around, and obviously this depends on what organ site is being studied, but age, the presence of HIV infection, prior and concurrent malignancies. I mean, many of us have struggled with the issue around small renal masses or a very low risk prostate cancer where someone is on active surveillance and they're ineligible for many trials because of the history of a current or concurrent malignancy. But in truth, whatever you're studying may not really be impacted by that very greatly. So these paying attention to these actual eligibility criteria and the relaxation of these criteria is important for us as urologists planning trials. Lastly, in the last couple of minutes, I just want to talk about an effort that I've been involved in over the past few months called CUSP-2CT. This is an NCI initiative called Connecting Underrepresented Populations to Clinical Trials. It's a multi-level effort. In other words, looking at the community, health systems, local areas, and patient-level issues and barriers to develop both outreach and in-reach types of initiatives to reduce barriers, and ultimately with a goal of increasing accrual to federally funded and especially NCI-supported clinical trials. We applied for this award, and I was fortunate enough to work with one of my scientific collaborators, and we were both co-PIs on this trial to look at our population in Ohio, and particularly we have 9 counties that we're working with around the state of Ohio within our catchment area to try to increase representation on clinical trials. In this effort, we're really looking at multiple levels of issue and challenge and barriers that people face. And our goal is to really get a baseline assessment of some of the issues that our potential referring physicians and other collaborators around our catchment area might have. We're creating a multi-level intervention based on some of that data, which we'll be testing and then ultimately evaluating. This is our group and a group of affiliates that we're working with. All of these hashtag and colored areas are health systems and other collaborators from our cancer center research network, and then others that are outside of that network that don't normally have access to clinical trials, but would like to participate as sites. I've talked a little bit about the study design, but it's a multi-phase study that'll be done over 4 to 5 years. And what I think is exciting about this is that we're actually going to be going into the offices of the folks around our state and really looking at the challenges that they face in trying to screen patients, recruit patients, follow them on trials, and also have access to some of the most innovative trials. In this particular study, although it's not a study where we're looking at recruitment in a single trial, we're looking at it across multiple organ sites. I do think another very key piece is that we're looking at all the various levels that impact accrual, everything from the community to our own health systems, to the community health systems, to the provider, the actual doc, and what support they have in clinic, and then also at the level of the patient and family. This work was based in part of some work we did with as a pilot in our breast cancer clinics to actually use an intervention with a patient navigator to be able to screen better and to actually help patients stay and be retained on clinical trials. And actually, the clinical trial recruitment went up over 14% in that group that had the patient navigator. So it really was a very effective strategy. That's only one strategy, but it's an example of a provider and patient level barrier that we were able to overcome with an actionable initiative by the installation of a patient navigator. So I'll just conclude with just giving you a sense of some of the various strategies that we're going to include within this work. At the patient level, everything from interpreter services, patient navigation, community outreach and engagement, and also directly looking at the challenges that we're faced with, that our community folks are faced with, addressing those barriers directly. At the provider level, looking to our research groups to identify the challenges that they have, providing a provider level education and also education around the importance of diversity in trials, the importance of clinical trials, and also looking at the effect of some of the interventions that will be very directly related to any barriers that arise. And then at the system level, really focusing again on reporting of race and ethnicity. We have the same problem, by the way, at our own institution. Working with some of the tools and AI-based tools that we're using now for screening and EPIC. I don't know if you guys are using that or whether that's been effective for you, but that's a strategy that we're piloting now in our breast clinics. And then really implementing plans to try to accrue and also retain patients on trials. And lastly, at the community level, really trying to strengthen some of the relationships we have around research. I feel like through COVID, although we have maintained our relationships across our catchment area, most of that has become remote. And I do feel like that we have had some impact, some negative impact on our accrual, particularly of historically underrepresented patients. So we'll be kind of doubling down again with those community advisory boards, with local leaders to try to regain information about what's important to them and requesting feedback. With that, I think I will stop. I hope I've been able to just impress upon you, and I don't know if you're thinking about it as much as I've been thinking about it over the last several months, but just impress upon all of us that even as urologists, there are many basic things that we can be doing to really think about enriching our trials with a diverse population and reporting and recording information clearly and consistently. And also thinking about eligibility criteria and also considering the space from where our patients are coming and what they need in their space. So considering social determinants and what resources we have to address those. I'd be happy to answer any questions.
Two questions. Great talk. One, you didn't mention gender equity. So for trials in colorectal disease or lung cancer, what strides have been made based on gender?
Yeah, actually, I was looking at some data recently from one of the reports, and it listed, now this is for cancer trials, there was 52% of women in trials. Typically, women have been an underrepresented group. So I think there definitely has been improvement there. There is still a focus. Even the National Academy report has a focus for women and women's health in clinical trials. I think it's actually gotten a lot better for cancer trials. Now, part of it too is the breast trials tend to really kind of overwhelm everything. And so the numbers always look great because of those trials. But yes, historically, women have been underrepresented.
The second question, and you kind of touched on it at the beginning and end here, is accruing patients from a distance. I was looking at your map in Ohio and you mentioned of Appalachia, and it's something we struggle with is to how to get to communities where travel is a real barrier. You did show some sites where they could go in the state, but how are you going to manage that and people who are in distant communities who don't have the luxury of being able to travel to these regional sites easily? It's a barrier here. We struggle with it.
Yeah, and we do too. I mean, some of what we're going to do, and we know some of the answers, and one of them is travel. So there has to also be a commitment and investment. Some of the sites that we're looking at are part of our, some of them are part of our research network. So we share Epic too. And that allows us to help with screening. It allows us to help with remote visits. What it doesn't do is do anything for the people that are not on that remote system or for the people that are challenged, with adverse events. So there's an educational curriculum that's being developed for the support staff from our outer sites. That's not going to solve it. I think the patients themselves also are, I think they feel, what's the word I'm looking for, but they're depressed by the fact that there is this travel burden and the toxicity of being on a clinical trial is real. There's that time, even when it's remote, there's a time requirement. So we're trying to tease through some of that, but it's going to require more people. The patient navigation piece, I think, can help because they can help bring resources to patients that they didn't even know they were eligible for. the cancer trials with older and retired patients may benefit from that. But for those actively working, it's going to be a real challenge. What have you guys done? I'd be interested to.
We struggle with the same thing, and the other thing is getting good trial compliance at remote sites. I mean, these trials, I feel compliance, starting and trying to get that. I think low, non-intense clinical trials are one thing, and certainly registry trials. But you know, big time interventions can be challenging to do at remote sites.
Well, and I'll air some dirty laundry. As you think about that, we have also tried not to create disparities where at the mothership, they're the complex, super innovative trials, but out and around, you have registry trials, and essentially you're creating a bit of a two-tier system. So I feel like we have been at risk for that in our efforts to try to really engage other folks outside of our main campus. So it's going to be a challenge. I think it's going to require us to just have a different kind of thought about the recruitment of docs that are working there too, and incentivizing docs to be part of the remote care of patients, because it is very difficult to try to, if someone isn't regularly working in those more intensive trials, it's very difficult to even envision kind of recruiting and retaining patients in those trials.
Sort of following up on this, the concept of outreach versus us reaching out. I think we've talked about this in our department in the past. And the biggest problem for a lot of patients coming here to drive here, parking, all that. Is there any mechanism to get the faculty and people part of the trials to actually do their visits where the patients are?
Well, we have really been growing our home care, our home health as part of the continuum of care that we're delivering. So we now do have the infrastructure to be able to, and some of it's remote, remote telemedicine, but also remote assessment of vitals, and using technology to actually help us with this. But we have the infrastructure to give acute care, fluids, vitals, assessments in the home. And that's something we've been growing over the past year and a half. So in theory, we have an infrastructure where we could deploy a group. Now, some of that, then you just have the investment that's needed for that group to regularly provide that kind of service. Now, we have a lot of screening services that do, take the care and the screening to the patient and to the population with mobile units that provide lung cancer screening with a mobile CT scanner, mobile breast cancer screening. So we do have the capabilities on the screening side, but that's not like, those are registry and screening trials. So again, you're kind of creating a little bit of a two-tiered system.
We're finding, Marshall, in that regard, getting regional is not that challenging. We're making a big effort to go to South Bay, Berkeley, East Bay. We have these relationships with hospitals. Some of whom fear us. We like to get the green beret. They're worried about that. But I think getting faculty to go back and forth 20 minutes is can do that. And many people want to live in these communities. I was building an Anderson house over in Orinda. But I think the challenge will be is when you get out to like Modesto, Fresno, Kaya, and you can't, doing CAR T therapy out there, it could be dangerous. So I think regionally we do well. I think the big challenge for us is to think how we get out 50 miles, 60 miles, and infrastructure. Some of these trials is really quite and the communities may have somewhat of an interesting research, but may not be driven by the same research effort.
We're trying to partner with some kind of mid-size health systems. There's a couple, one in Dayton, which is about an hour and 20 minutes, hour and 30 minutes from us. another one that's north that is about an hour and 20, 30 minutes. That's part of another very large health system that we partner with, Mercy Health, Mercy Bon Secours. We partner with them on some other research initiatives. So we're trying to use some of these other partners to make the investment to have these kinds of research units.
Yes, we're doing the same thing with John Muir, or in general. But even there could be challenging.
Yeah. Dr. Washington.
I guess I'll use the microphone. Amazing talk and exciting last slide. I guess my question is really, when developing these multi-level strategies, it's impressive the infrastructure required at each of these levels. And it wasn't something that just developed around the grant proposal, but the work that you've done, Dr. Paskett's done there. I was wondering if you could speak a little bit about how you've been able to leverage those infrastructures to develop the strategy for the proposal. How much of that was kind of existing and supported, but maybe not linked in this way to this proposal?
Yeah, again, coming clean. Electra Paskett is just a phenom. She's an internationally known epidemiologist and just a great scientific partner too. But she leads our Center for Cancer Health Equity and has done so for 20 years. So she has very established relationships. And so the infrastructure that you're seeing here could never have been created just with the grant dollars. But the grant dollars are allowing us to build off of a number of other initiatives that we already have ongoing. And there's already a team of 25 people in the Center for Cancer Health Equity across multiple ethnic and racial groups that already have established relationships, already are parts of community advisory boards. We already have leaders in the community where there's trust. So it is the kind of infrastructure that I think is required to participate in a grant mechanism like this. And I would say that that's why we were competitive.
So in the first panel here, assist with overcoming barriers to trial participation. My question is, from a patient perspective, when you think about participating in research, personally, I would have thought, prior to med school, or it wasn't until maybe midway through med school, I was like, yeah, I would want to participate in a clinical trial, because I think there's a little bit of speculation as a patient that you're being experimented on. And I think that's kind of a big barrier that we see when we recruit for research at our county hospital as opposed to the academic hospital. I think our numbers, we're trying to overcome that general speculation. Do you have anything built into this strategy that kind of specifically focuses on that barrier for patients?
Yeah, that's an important comment. And I think it does go back to the pre-existing relationship and the reputation. Our center has at times had a less than stellar reputation in terms of supporting some of our most economically disadvantaged patients in our region. We've made a lot of inroads, a lot of investments, and a lot of efforts over the last, 10 to 15 years. So it's getting better, but people have a long memory. And for our success in this study, I think is going to really extend from the relationships from our Center for Cancer Health Equity. But I would say the amount of education, the amount of real collaboration where we're in the community, not asking for things, but participating in health days and health fairs and screenings and providing, community-based type education in a community site, whether it's a church or whether it's another ongoing activity, and we partner. The community needs to see that to have that trust. But in my experience, when that trust exists, and we see it all right in our own clinics, when your patients, when you approach one of your own personal patients to participate in the trial, they'll do it in a heartbeat because they know you, they trust you, they know you have their best interests at heart. So I think it's just about trust and being there and not being there just to ask for something.
Yeah, so I got a little break here. Thank you.
We're going to take a 20-minute break and then reconvene at like 9:40. Thank you.
Use the term benign. I'm not gonna use the term benign, and I'm gonna challenge everybody in here. We have to get rid of the word benign because none of the stuff in quote the benign world is benign. But for those of us who do not do the cystectomies on a regular basis, we realize that these patients can be quite sick, and on our M&Ms frequently see a little M associated with these cystectomies. And I think it was Sean Elliott that says it's not when we'll have a complication. He says not if, it's when we'll get the complication with the cystectomy. I said maybe that's just under your hands, but they are very truly challenging cases, and there's so many different aspects to it. And we're looking forward to hearing Cheryl's perspective on that approach. Thanks. Okay.
Thank you. Well, I feel like as my career is moving on, I get thinking about an issue that comes up with a patient, and before you know it, I want to chat about it and talk about it. So this is again happening with this topic. I feel like when I started my career, 20 plus years ago, I felt a little bit like a hammer. Whenever there was a high risk bladder cancer patient, they were getting a cystectomy. And things have really changed in the disease. And so I thought it would be nice to talk a little bit about that. Our group has participated in some of the trials that have been ongoing and also really shifted how we're caring for patients. So I have no disclosures. You've heard about Ohio State already. I thought maybe I would just use this patient as an example for what I was talking about. This is a gentleman who was referred to me after he had gross hematuria, saw his regional urologist, had a biopsy that showed low-grade TA disease. And the imaging is up there, is right up here. And he had an axial scan. He didn't have any nodes or metastatic disease or hydronephrosis. But you may see that he's got this large mass. He had a diverticulum here, and it was really, pretty bulky mass. And this is the coronal images here, so you can see it. This gentleman was reasonably healthy. He had a few maybe chronic conditions, maybe hypertension, but overall certainly would have been a surgical candidate. And with this very bulky disease is certainly something I talked with him about. But increasingly, I feel like patients are saying, no, I don't want my bladder out. What else, what other treatment options do you have for me? So over time, certainly we have exploited the transurethral resection. There are more intravesical agents now to exploit, but we still can't forget about a very definitive treatment plan, particularly for someone like this, in cystectomy. Now, having said that, he refused that. And I wasn't confident about the staging, but I was very suspicious that he may have had an invasive tumor. So I did took him for a TUR because he had just really had a small biopsy, and I thought it was low-grade TA disease. So I spent, I don't know, maybe 2.5 hours resecting, and I still wasn't done. It was a lengthy TUR. And I said, well, to be honest, we'll probably get the information we need and we won't be back here. Well, it was all low-grade TA. It's all low-grade TA. So we went back. It took me 3 TURs to clear and do a final kind of restaging because it was in a diverticulum, which made it a little bit more challenging. But we resected it all, and over time, this is kind of what it looks like. He didn't want to get any outlet surgery done. He didn't want to get a diverticulectomy. I mean, so he's kind of someone who's risk averse to any kind of surgical intervention other than kind of the endoscopic type of work. But it was just another example of the what would have easily been managed with a cystectomy in the past that really is changing how we think even about bulky disease. I still feel that radical cystectomy is such an effective operation, really, in terms of local control. When you look at data from the RAZOR trial, the rate of local recurrence is less than 5%, and if you look at it right in the cystectomy bed, it's 2.3%, and that's very contemporary data. So it's an effective operation, but unfortunately, it's also a complex operation, and there are multiple complications and morbidities that we still need to contend with, in addition to, as we'll talk about later, some issues around quality of life. This is again from that RAZOR trial, which compared open versus robotic cystectomy. And this is just some of the complication rates that occurred with both the open and the robotic procedure. And we still struggle with infection, as you see, UTIs, sepsis, superficial wound infections. I mean, a lot of this list is infection. And then, of course, small bowel obstruction and that kind of thing. So I just show this to say it's an effective operation, but there is some morbidity to it. And probably around 4% or so mortality rate, in the first 90 days, 3 to 4%. So it's not an operation to use lightly. I'm excited that we have worked to improve the operation and to study our improvements. I was just talking about clinical trials. I've been really excited about the strategic approach to trying to improve what we do in the operating room. And this is some data here from the LEA trial that was a multinational study that came out of Europe, looking at patients undergoing radical cystectomy with patients with invasive disease, and comparing patients who underwent cystectomy with extended lymph node dissection versus a standard one. And the trial was powered to show a 15% advantage in 5-year recurrence-free survival. Now, the trial was criticized for a number of factors. One, patients with T1 disease were permitted to enter the trial, and they're going to have a much lower rate of nodal spread, and would have better recurrence-free survival outcomes anyway. And they were about 14% or so of the population, so it wasn't small. But there were also some questions around some of the power calculations, and like often happens when you're comparing two groups, those who were doing the standard node dissection seemed to do a pretty good standard node dissection because the counts for standard were a bit higher than expected, 19, as opposed to historically they've been around 10 when you look at some of the retrospective data. So in that study of over 400 patients, the extended node dissection mean was 31, so it's pretty high, node rate. But in the end, looking at their primary endpoint, 5-year recurrence-free survival, there really wasn't a significant difference between the two groups. Having said that, there was a little bit more, there was a higher rate of complications over grade 3, with resulting in lymphoceles in the extended lymph node dissection group. So essentially a negative trial and additional complications. And like I said, this trial was criticized for a number of reasons. And of course, the Southwest Oncology Group was doing another trial of its own that we had here in the States. And that, I'll just mention that that study did have secondary endpoints of cancer-specific survival and overall survival, both which were similar between the populations. But so the SWOG study looked at over 600 patients that had muscle invasive disease, so no T1 disease. And these patients were able to undergo neoadjuvant chemotherapy, and they were randomized to standard pelvic lymph node dissection versus an extended lymph node dissection. And this study, unlike the LEA trial, was powered to detect a much smaller difference. So that's part of the reason why they have another couple hundred patients. So a 10% improvement in 3-year disease-free survival. The patients that had high-risk disease after cystectomy were permitted to have adjuvant treatment. The results from this trial were just presented at ASCO over the past week. I wasn't at the meeting, but I believe Seth Lerner did present these from what I can see. But this also wound up being a negative trial. When you looked at the 90-day mortality rate, and the abstract says 26 patients, although we only have 16 in extended and 9 in the standard, that equals 25 by my math. But anyway, I wasn't at the meeting, so I didn't hear that. But so there may have been something else. But essentially, there was a little bit, you can see that the mortality rate was just over 4%, but there was a higher number of deaths actually in the extended lymph node group, although I don't believe that was statistically significant. But in the end, for the primary endpoint of disease-free survival, there was not a difference between the extended and the standard groups. And the overall survival was also similar. But when you look at the higher grade complications, so those that are grade 3 or 4 or 5 being death, you'll see that there was a higher number of these complications in the extended lymph node group. So that's really important to note. Not only were the survival rates similar, but actually you could do harm by actually doing extended dissection. So I think the field is really going to have to think deeply about how we're managing lymph nodes for patients. But because there is the risk of greater complications and perhaps a few additional deaths. But I still am very inspired and proud of our field for doing this work to actually change practice in the operating room. As cystectomy, because it is a complex and morbid procedure or associated with significant complication rates, certainly techniques have been developed to try to reduce those complications. And one, of course, is one approach was to consider using robotic cystectomy as a way to reduce complications. And you all may remember the RAZOR trial that, again, compared robotic versus open cystectomy. And the primary endpoint for that trial was 2-year progression-free survival. This trial also was powered to show that robotic cystectomy was not inferior to open cystectomy, and that's exactly what it did show. I mean, there was no difference between the groups as related to progression-free survival, as I'll show you. But there were some differences, just technical differences, as it relates to blood loss. So there was a reduced risk of blood loss and also transfusion rates for those in robotic cystectomy, although they when you look at the blood loss seemed very high to me in the open group at 700 cc's of blood loss, and the significant transfusion rates in the open group for seasoned surgeons. And these were seasoned surgeons here, but those numbers did seem a bit high in terms of units transfused. for both groups, and these were US patients. So the progression-free survival was similar between the groups. That was the primary endpoint. But of course, there was some criticism of that trial because many people managed the diversion. They didn't do it fully intracorporally. So many thought that that's part of why we're not demonstrating the benefit. But the IROC trial that came out a year or so ago then looked at this again from a technical standpoint, comparing open versus robotic cystectomy, but fully intracorporeal diversion and cystectomy. And this, the endpoint in this study was a little different. The distribution of days alive and out of the hospital within 90 days of surgery, which I think is actually a very meaningful endpoint for patients. So I really like this endpoint. We were talking about our personal missions yesterday, and everybody, all the residents know that I tend to be very focused on the human condition, and I'm a big patient advocate. So I like this endpoint in part for that reason, because it is based on can the patient get out of the hospital, and so there was about a 2-day, a little over a 2-day advantage to for those who had robotic cystectomy. Now, some may say, is that meaningful? I can tell you that in the day and era that we live in, a 2-day difference in length of stay is very meaningful. A 1-day, a 3/4 of a day length of stay in this day and era where beds are very challenged to come by, at least where I am, this is very significant. So you know, I think when you look at the lifespan of somebody or their recovery period, you may say, well, is that meaningful? Well, from a systems perspective, that's meaningful. From a patient, you know, perspective, that could be different. But of course, patients care not only about the cancer outcome, although obviously that's primary, but they also do care about health-related quality of life and also patient support. What are they going to do when they get home? So these are all things when you're trying to counsel patients around cystectomy, like these are some of the key issues. How are you going to recover? Who's going to care for you at home? You know, how is this going to impact the other areas of your life, your urinary function, your sexual function, your bowel function, your ability to connect with your friends and family outside of your home? So these are all major issues. So when you look at the data from the IROC trial, and they had a number of secondary endpoints, some of them related to health-related quality of life, and these were assessed through various instruments. So they looked at the EQ SDSL and another EORTC health-related quality of life instrument. And on this one, which is looking at quality of life, actually higher scores are better. Okay. And in this one, higher scores are better as well. So what you saw was that there was a little bit of an advantage to robotic cystectomy in terms of early recovery. So by 5 weeks, those who had undergone robotic cystectomy had recovered a bit more than those who had had open. Yet you see by 12 weeks, that has, it's pretty close to the same. So again, is that meaningful? Hard to know. Probably not as meaningful in the person who's, you know, less active than someone else who might be more active, going back to work and maybe have small kids around, where recovery is really paramount. And we saw something similar here with a little bit more of a delayed recovery out to, you know, out to even 12 weeks. But again, probably very, very subtle by the time you're at 12 weeks. The disability is an important issue, I believe, and this group looked at the WHO, one of the WHO instruments to try to measure disability, and on this scale, actually being lower is better. Okay. So when you see the blue is robotic, the yellow is the open, you'll see actually again that there's a little bit of an advantage for earlier, for less disability earlier on for those having robotic cystectomy. And this is another, just a test, again, around stamina, strength and stamina. It's a 30-second chair to stand. So how many times can someone stand up and down? I think it's within 30 seconds. And you measure that. So a higher number is better and shows more stamina. And here you'll see that at 5 weeks, again, a little bit of an advantage to robotic cystectomy, and that extended to 12 weeks. But by the time it's around 26 weeks, it's pretty similar. So I think that's important as we consider activity, recovery. And these are the kinds of things that whether you are an open cystectomist or a robotic cystectomist, I think these are things that we need to counsel our patients about. And based on the patient, that could be a relevant issue. We also looked at the creation of a survivorship care plan to help with transition from surgery into, back to someone's community. Of course, a lot of these surgeries are a bit centralized. So when the patients, who are traveling several hours to see you want to go back home, they're almost in a bit of a desert in terms of people knowing what to do and how to continue to manage the care. So survivorship care plans had been felt to be a tool to help patients become aware of their disease process, their recovery process, and also the people that are caring for them to kind of have a guide and a path to follow when especially if they're several hours away from where they're getting their main care. So to actually develop this, we got a large group of people together, very multidisciplinary, to create the survivorship care plan. We had people from colorectal cancer, people from from the breast cancer world, and created a care plan that we then shopped through patients and providers, docs and APPs, through several structured interviews to try to get their feedback on the instrument. And then after that, in the next phase, we actually tested it in, I think we had 8 or 9 centers. We actually tested it to see how feasible it would be to use in the clinics. What we found was that there were some challenges, surprise, surprise. And most of the challenges were around, workflow. And what we also found is that most of the people were filling them out outside of the space of the patient. So it wasn't exactly what we planned, but I think we got a good base series of questions that we've now tried to put into Epic so that people can respond to some of the same queries on their own and at a different pace. And also that other docs that have access to our Epic can see those same issues, questions, and also surveillance plans. One of the things that we thought was important was not only the surveillance of the cancer, but making sure that when patients enter their survivorship plan for one malignancy, that they don't forget about all their other health maintenance from their non-cancerous, I won't say benign, but from their non-cancerous conditions, but also from all of the health maintenance and prevention and screening for other malignancies. So we had a number of patient and family resources with phone numbers and information related to financial issues, related to urinary supplies and catheters, related to device companies. So it was just a great way to package a lot of things, a lot of bits of information. Now you may say, we've got a great advocacy organization in the Bladder Cancer Advocacy Network, Beacon. Well, we have a lot of patients that actually aren't regularly online and aren't utilizing those services, even in 2023. Now, their families usually are, their kids usually are, but we do still have people who actually want paper. So having said that, we also appreciate the importance of this being interlinked in a patient's portal so that they can access the information, but also so that others in their world, including their own docs, can access the information. So I want to mention another patient that I have had for the last several years. This is a gentleman he's 71. He's a healthy 71. He works out. He's very active. Has just a prior history of testis cancer from 20 or 25 years ago, and he did have an RPL&D, and he did not have any radiation. I never able to get the pathology, but he did have an RPL&D because he's got a big scar on his abdomen. But he is someone who has an important piece of social history, and that his wife has dementia. And he is the primary caretaker for his wife. And that really does guide a lot of his decision making. So I met him back in 2018 when he had hematuria and was seen by a regional urologist, had a TURBT, and was diagnosed with early invasive disease, clinical T1 disease. And his urologist regionally was recommending that he have a cystectomy. And that was his first ever, T1 tumor. And I said, well, why don't we, restage this and let's really try to fully assess your bladder and fully stage things. So he actually was restaged, and there was residual disease there that we resected. He, we talked a lot about it. He was very committed to bladder preservation, which I thought was not unreasonable. And we went ahead and we moved forward with an induction course of BCG. And then at his first check, he had some new TA disease, high grade, non-invasive disease, and he also had carcinoma in situ, which we hadn't really identified before. It's possible it could have been there, but I did go ahead and we talked about the results, and we moved forward with a second reinduction course of the BCG. So he, with almost every surveillance point, he would have recurrent disease. So the very next point here, he had an invasive tumor. So he was really had an adequate course of BCG, and now he had a recurrent, and pretty rapidly recurrent tumor. And we discussed his BCG unresponsive state. We discussed cystectomy, and again, he was really deeply committed to bladder preservation. During this time. We then moved forward, or he kind of took a break, actually, and took some time to think about things. I wound up restaging him again. He hadn't gotten anything at that point. It just really resection. And then I did talk him into having another intravesical therapy. So he wound up getting induction, gemcitabine, and docetaxel. And he did reasonably well, and we kept him on a maintenance course here for a year. He then recurred again, but it was very low volume disease, kind of a minute non-invasive tumor, and he had a small focus of CIS. At the time, we had the erdafitinib trial open, and we tried to see if he was eligible for that. He didn't have any mutations, so he was not eligible. Pembrolizumab had been approved, I think, by that period, but he was very leery to do that because he was leery of the systemic side effects, but we had talked about it. And, or we had another trial. It might have been in the context of a trial. I think it was the BCG Pembro versus BCG. And ultimately, he wound up getting mitomycin C, which all of these points, I'm talking to him about cystectomy, and each point he's really staunchly committed to bladder preservation. Needless to say, he recurs on mitomycin pretty quickly. And then we talked more about pembrolizumab. We tried to get him on the pembrolizumab trial that we had open. And ultimately, there were challenges in getting him on the trial, and we just treated him because it was FDA approved at this point. He did reasonably well for about 6 months, not very long, and then recurred again. By this time, Adstiladrin had just been approved by the FDA, and we thought about using that because he's still refusing cystectomy, but the drug was unavailable. So with that, I put him on valrubicin. I put this patient here to show how different this is from when I first started. I mean, we would have probably had a cystectomy up in, years ago. But, and I can't say which one is right or wrong. We talked about always trying to intervene and achieve the cure before someone progresses, knowing that they're likely to have a better outcome than if at some point he were to progress to muscle invasive disease. But our prior or historic approach to pull the trigger with cystectomy is really something now that has changed. And we really have to, I think, consider, now, of course, we always consider the patient's interests and commitments, but because we have so many therapies, I think we need to better understand at what point is the patient at higher risk. There's a rate of progression or risk of progression accelerate as we move through all of these various treatments. I don't know the answer to that. That's something we need to look through. But part of, I think part of the thoughtfulness around all of these agents and the ability for us to actually study numerous drugs without stumbling on having the control arm, because we didn't really have a good control arm, flow from the FDA definitions for BCG failure. Before this, the FDA was reluctant to accept and approve any intravesical agents for non-muscle invasive disease because we couldn't conform to the specifications around trial design and around controls. Well, and Seth Lerner was very active in a lot of these discussions with a number of people, but you are all aware of these definitions for BCG unresponsive disease that really pulls together the most aggressive patients from all of our old and historic categories of BCG failure. So it's the piece of people who relapse very quickly. It's the people who are refractory with continued CIS. It's the people who have rapidly recurrent invasive disease. The pembrolizumab, when we look at some of these newer agents, especially those that are now approved, pembrolizumab approved after the Keynote 57 trial, and this was a phase 2 study that essentially looked at patients who had intermediate and high risk bladder cancer and were treated with pembrolizumab, and then they followed the patients according to these cohorts that map to some of the expectations that the FDA has put forward for industry for submitting their data from new and novel agents. So this includes patients who have either carcinoma in situ with or without any papillary disease, and it's got to be high grade, versus patients who have isolated papillary disease, again high grade, without CIS. So those are the couple of categories. And so looking at the 3-month complete response rates is key, but also obviously the 12-month response rates. Adstiladrin is another agent that was just recently approved. It's an adenoviral vector gene system where essentially interferon alpha is substituted into this adenoviral vector that is incorporated into the cell and into the nucleus. And with that, that cell is producing interferon alpha, destroying the cell, and then having the impact on the patient's disease. I think one of the, we did not participate in the Adstiladrin study. We did participate in the keynote, but in the Adstiladrin study, the nadofaragene firadenovec, an important point for the patient is the timing of the treatments, and that instead of the weekly treatments for 6 weeks like we're very accustomed to, these treatments are happening every 3 months. So you imagine how attractive that would be for a patient, particularly if they're traveling from a distance. Although gemcitabine and docetaxel are, have not been studied prospectively, they have become really a de facto second line treatment for patients who have BCG unresponsive disease. And some of it's based on this multi-center retrospective study of almost 300 patients. And the interesting thing about this study, most of these patients are intermediate and high risk. They've had prior BCG, so many of them are heavily pretreated, but despite that, they had really outstanding recurrence-free survival when you look retrospectively. So it's important to know that this study was not a prospective study, but very provocative nonetheless. And when you look at patients who failed and ultimately required a radical event or cystectomy, really that was less than 16% in a very high-risk population. Only 4% had progression to muscle-invasive disease. If you parse out some of those patients from the retrospective data, when you look at the recurrence-free survival in either the high grade on the left or the BCG unresponsive, so it is a parsed out population, you still see some very provocative results with 12-month recurrence-free survival in the all high grade group, at 65% in heavily pretreated patients. And at 2 years, 52% recurrence-free survival, which is outstanding and far beyond what we've seen in many agents over time. And for the, for the BCG unresponsive group, if you parse out the carcinoma in situ and the papillary disease, you'll still see, even for carcinoma in situ, very promising results in the retrospective setting. I borrowed this slide from Max Cates and Seema Port, and she's not here, unfortunately, now, so it's good I would not showing her own slide, but I did have her picture there. But it does look at some of kind of our second and third line agents that we have now for non-muscle invasive disease. And I think a critical thing to note for pembrolizumab, for nadofaragene firadenovec or Adstiladrin, and for gemdosi is that there's real activity in the 12-month complete response rates. And these are in, again, high risk, very high risk patients, especially in the gemdosi. So, and the intravesical agents, of course, have much less toxicity than the systemic agents. Now, N803 was kind of a newer immunologic agent, an IL-15 superagonist that has had some really interesting results recently, and they were going up to the FDA. Their application was not approved. I believe it's because of some manufacturing issues, but their application for FDA approval was not approved. But gemdosi, because of all of this data that's been seen in the retrospective setting, and because of the lack of availability of BCG and sometimes challenges with intolerance to BCG, there's been an enthusiasm to try to find agents in the BCG naive space. And this was some data presented recently. I love this actual slide. This is like from the group or from the journal. It's just a beautiful slide. They looked at 107 high-risk patients, 47 with carcinoma in situ, 55 with T1 invasive disease, treated with TURBT, and then treated in the BCG naive space with gemcitabine and docetaxel. And I would say that, again, very provocative findings. They have, there's about 50+% adverse events, and some of these are very minor. that we're often seeing and accustomed to with intravesical therapy. My experience in using gem tax for a lot of patients that is very well tolerated. Less than 4% of patients actually had to discontinue the therapy. But the 2-year recurrence-free survival rate was 82%. Now, again, this is retrospective, so it's important I want to emphasize that. Nobody progressed, and the 2-year cancer-specific survival was 100%. So this is very, very provocative, and that has led to the BRIDGE trial, which is currently accruing patients. We're also part of this study looking at gemcitabine and docetaxel in the BCG naive space for non-muscle invasive disease for patients with unresponsive disease. So it's when you see the eligibility criteria, and hopefully it's relaxed. No, the patients are high risk, high grade TA, carcinoma in situ, or invasive disease, high grade T1. So these patients will be getting BCG versus Gemdosi, and the primary endpoint here is actually event-free survival, which obviously would include cystectomy. So this is ongoing, and I don't know if you all have it open here, but I think this is going to be an important trial for us, and then open the door for a lot of other agents to be studied in the BCG naive space. Just a comment about erdafitinib, because this is another alternative for patients with BCG unresponsive disease, designed to look at recurrence-free survival. The ongoing study that they had, which is now close to accrual, included 3 cohorts. There was one group 1, who was kind of more traditional with the traditional endpoints that we've been talking about for some of the other medications, some of the other drugs. And then there's a cohort 2 for CIS and a cohort 3, which is like a marker lesion study, leaving a small amount of tumor left. And these are primarily intermediate risk patients. And I believe Sia Demansek just presented this at ASCO. Again, I wasn't at the meeting, but from what I can see, it looks like they have been able to see some responses. This is a very small group. I think they had data on 8 patients. But there has already been some response with the marker study, with some of these tumors actually being treated and eradicated. So we'll hear more about that study. Right now, it's still ongoing, and that was some interim results that they presented. I want to just make a comment about the Cysto trial, which is one we also are participating in, an observational cohort study led by Angie Smith and John Gore, really to get at the issue of decision-making and quality of life for patients who are making that decision between intravesical agents versus cystectomy, kind of like the patient that I just presented, with multiple attempts at trying to preserve the bladder. So this study is doing a lot of qualitative work with interviews with patients and caregivers, with a goal in mind of looking at quality of life of these patients who are either electing to retain their bladder and undergo multiple courses of secondary, tertiary medications, or to proceed to cystectomy. I think my watch is up. How are we doing on time? I just want to. We're good. Okay, great. As we think about our approach to cystectomy in 2023, again, I want to think that things have evolved really, and including in the context of bladder preservation. I've been an advocate of bladder preservation for many years, but I would say that I don't know that that's the resounding sentiment from our field. But I do think that there are patients who can be very carefully selected, and ideally, they're having muscle invasive disease, a real complete TUR, no carcinoma in situ, no hydronephrosis, 1 tumor, and good bladder function. I mean, there are people that can be super selective and I think have good results from, from bladder preservation. Even in the retrospective context, there's been some data to support that. This is some data from Mass General looking at years, decades of patients that had been on and off trimodality therapy, and almost 500 patients with muscle invasive disease with a long follow-up over 7 years. Now, again, this is retrospective. When this group from Mass General looked at some of the longer-term outcomes, 5 and 10-year overall survival, really you have to believe that there is a role for trimodality therapy for patients with muscle invasive disease. Not for every patient, but there is a role when we see 5 and 10-year overall survival at 57% and 39%. Over time, the salvage cystectomy rate has also improved significantly. This group looked at these outcomes over time, and what you'll see is the red lines represents the most current time period from 2006 to 2013. The green line, 1996 to 2004, and the blue line, 1996 to 1995. So one of the things that I think is just an important observation from this work is that over time, when you look at whether it's overall survival, disease-specific survival, or bladder intact disease-specific survival, we've gotten better with selecting patients. And as a result, we've seen complete response rates go from 66% to 88%, 5-year survival from 53% to 75%. Salvage cystectomy really to improve substantially down to about what it is, I would say, in a contemporary setting, around 14 to 15% in this day and age. Now, that is all, not all. It's in part very selective, patient selection, very rigorous patient selection. And I feel like there's nothing wrong with that. Just, a few days ago, I did a TUR on someone who had a very small tumor. It was about 2.5 centimeters, isolated on the lateral wall, and resected it. And the center of it was just burying deeply invasive into the wall. Now, I did as radical of a TUR as I could, but I feel like, and this patient has a number of comorbidities too, I feel like this is an example of someone who might do well, might do very well, a very small tumor, readily resected, but clearly is going to have, I haven't gotten the path yet, but clearly is going to have muscle invasive disease, and clearly will have some morbidity from radical surgery. I have been involved with efforts for bladder preservation, since 2000, in early 2000s, when we were looking at a regimen, gemcitabine, with twice weekly radiation after maximal TURBT, and at that time was able to take a group of 24 patients and really attempt to find the maximum tolerated dose, because at that time gemcitabine wasn't being used in this context. We were able to find that maximum tolerated dose, but there was a fair amount of GI toxicity, and that did limit some of the dosing. But having said that, as we followed these patients over time, a substantial number of them, at over 40 months, still had their bladder intact and were alive and doing well. Now, some of them had failures, and this is just an example of the patient's failures and where the distribution of failures were in those patients in this original. This was a small group. It was 24 patients. But I think what you can see is that over time, and some people had multiple failures, particularly in the bladder, we were actually able to salvage the good majority of those patients with TUR and with intravesical therapy. Now, some had distant metastases, probably it was about a third what you might expect. And this is just an example of, this is just the Kaplan-Meier curve for the patients with bladder intact survival. And at 5 years, that was 62%. Now, this is a small group. It was 24 patients, but this is the same group that we followed with a regimen that really was not a standard of care regimen at that time. And these are the patients, those same patients, and their overall survival and disease-specific survival, which essentially at 5 years, really you're looking at 76% overall survival. This regimen was then adopted into the RTOG 0712 study that I participated in. And one of the important parts of this study is that we were looking at the regimen we just talked about, gemcitabine, with once a day radiation versus cisplatin and 5-FU with twice daily radiation. So this is a really major issue for patients having to have radiation twice a day versus once a day. But we used this regimen that was well tolerated to essentially look at a population of just over 60 patients. And essentially they got their TUR, they were treated, they had a cystoscopic assessment after their initial induction radiation. If they had a CR grossly, then they went on to have consolidated chemoradiation and adjuvant therapy, which there was a choice there. In this study, I think it's important to understand the primary endpoint, which was distant metastasis free rate at 3 years. The adjuvant regimens that patients could receive also did include gemcitabine, but at definitive doses. And when you look at the 3 and 5 year rates with the FCT is the 5-FU and cisplatin with twice day radiation. The GD is just gemcitabine with once a day or daily radiation. And you'll see the bars here for freedom from distant metastasis at 3 years, and then our updated data, which should be coming out in publication soon, showing that actually both regimen had pretty good results. When you look at the freedom from disease rate at 3 years, that's 70% for the 5-FU and twice day radiation. It's a little higher for the gemcitabine at 77% at 5 years. So that's, I would say that's very noticeable and impressive. And again, thinking that there's a role clearly for trimodality therapy for some of our patients with muscle invasive disease. The toxicity on this trial has been very reasonable. There's toxicity related to the systemic agents, as you might expect. When you look at the kind of the more directed GI ones, there were very few that were grade 3 and above. And that was in either the 5-FU twice day radiation or with cisplatin or the gemcitabine and single day radiation. When you look at the complete response rates, you'll see some of the data here. And one of the things I just want to point out that, again, with 5-FU cisplatin and twice day radiation, complete response rates pretty high. So this is after the initial induction radiation, and very high also for the gemcitabine. So these are patients who were treated and then had a cystoscopic evaluation with no evidence of disease on imaging. They did not have restaging TUR at that point. In looking at the bladder intact disease, distant metastasis-free survival at 5 years, again, both regimens doing well. The gemcitabine a little bit higher with 76% bladder intact at 5 years. And again, looking at the areas of failure, about a third with the gem regimen had distant metastases. With a 5-FU and cisplatin is about 50%. So I bring that study up because it's another example, I think, of how going to have to really consider how we're applying cystectomy, whether it's in the context of early stage disease that is eligible for some of the secondary, tertiary, and maybe even quaternary intravesical agents, or muscle invasive disease that is in a patient that is well selected. As urologists, I think we're going to have to get away from our hammer and nail philosophy and thinking someone's got muscle invasive disease and need to have their bladder out. I mean, I think we have to really consider the patient, consider their candidacy for TMT, and certainly at least have them have consultation with a radiation oncologist and medical oncologist. And in our group, we really try to accomplish that. It's not all together at the same time, but we do try to accomplish that. Just a few months ago, just one of my last couple slides, there was a propensity matched cohort in a retrospective study that was published trying to, and we can't compare cystectomy and trimodality therapy in this context, but what you'll see is a 3-to-1 matched cohort with patients who, cystectomy patients who've kind of been selected to resemble radiation patients. But to me, it tells me that there's a group that we could select that would be responsive to, and again, it's retrospective, but would be responsive to trimodality therapy with good outcomes. In this study of over 1,000 patients, we've got a median follow-up for almost 4.5 years. And what you're looking at here, what I would say is a very, very similar outcomes in terms of their recurrence-free survival. And this is the propensity match here, and this is kind of the unmatched group. And you'll see here some data which is kind of provocative, almost suggesting that the TMT may be better. But I would say, again, these are matched, kind of a propensity matched patients that are pulled out of a cystectomy cohort, not necessarily representative of a typical cystectomy cohort. And the patients are very selected, matched, propensity matched on size of tumor, degree of hydronephrosis, the degree of carcinoma in situ. So it's been a long discussion on cystectomy, but I'll just say in general, I still believe that cystectomy is an outstanding and effective operation. Proud that our field has continued to try to improve on the technical aspects of it. And I think we'll continue to do that at various parts of the operation. I hope we will. And we're going to just have to, I think, weigh really our patients, their needs and their eligibility for the novel agents and the additional agents that we're all seeing coming down the pipe. And it's, of course, there's more to come. The pretzel is also moving through studies. We'll hear more from the erdafitinib trials. So we may find ourselves then at some point with combination therapies. So really a lot to explore. And at some point we'll have to figure out where to draw the line. Anyway, I'm happy to answer any questions, and would love to hear your thoughts on the trimodality therapy story and how you all are using that and applying it here, whether you're working in trying to actually select patients to move them into trimodality therapy.
Question and one comment to the rest. The question, the issue of lymph node dissection interests me a lot because, for prostate cancer, we cannot show a therapeutic benefit to lymphadenectomy. We've looked at our series here at UCSF, and Sam actually reported it. And now, of course, at Memorial,
limited versus extended, there was no difference. And now it's lymphadenectomy versus no lymphadenectomy. So my question for you is, what do you think and also in those trials, I don't remember what the actual rate of positive nodes was, but what's your current take on lymphadenectomy? How did you do it on all patients? Do you do it selectively, and how extensively do you do it?
I feel like it would be a bold maneuver in bladder cancer not to do it. Only because I feel like we don't have good salvage therapies. In prostate cancer, if you don't do it and the patient fails, you kind of have a salvage to work towards. So and I don't have any data to show that there would be a benefit in not doing a node dissection. Here, we know that there is unlikely a benefit to doing an extensive node dissection. Of course, there's a lot of retrospective data that shows some therapeutic benefit to doing a node dissection, improved recurrence-free survival, reduced local recurrence rates from years back. So I don't see myself avoiding lymph node dissection. I think, we do it when we have to. We know in the real world, when people look at the large administrative data sets, that many people aren't doing lymph node dissections. And there are a number of studies, of course, in the literature suggesting different rates of node dissection or achieving 10 to 15 or 12 nodes or so would provide a baseline of efficacy for the patient. But I don't see us as a field of having that same discussion that's happening in prostate cancer, of avoiding or eliminating node dissection. But if you were going to have that discussion, we'd say, who would you have that with? Okay, so you might consider, the patient with high-risk non-muscle invasive disease that, has a BCG unresponsive state and or has not responded to some of the novel agents. So you could kind of envision that kind of discussion in that population.
The things that really changed us is because we have PSMA PET. So we with PSMA PET, we understood that about 30 to 40% of the lymph nodes that were positive were outside the standard fields for both radiation and surgery. So that was eye-opening. So here we've actually gone to intraoperative imaging. So with Intuitive, we have a PSMA fluorophore, and we completed a phase 1 because we have the Firefly camera on the robot.
Yeah.
So we completed a phase 1 study, very interesting, and now we're going on to phase 2. You mentioned the IROC trial. Now, if I recall, that trial, in order to be a surgeon in that trial, you had to show that you'd done a lot of cystectomies, and you had to have to tape a robotic cystectomy and send it to them for review. So that's a trial of a very carefully selected group of surgeons. It may not perform as well in the community. What are your thoughts about? So you mentioned you didn't go into diversion much, but are you doing intracorporeal continent diversions?
Yeah, our group is only neobladders. I don't think any of our group has done an Indiana pouch or a colon pouch, but regularly doing neobladders. Yeah. So what once was felt to be a real challenge and difficult really has become standard and commonplace. But also in the IROC study, and like many studies, there's probably almost 1,000 patients. I can't remember now, like whether it started with 1,300, and when they whittled down to the actual patients in the study, it's 800 or 1,000 patients that were whittled out. Some of the patients that were not included in that study were patients who had a lot of prior pelvic surgery or prior, So in other words, a standard patient, right? So there are other comorbid settings that were not included in that trial. So when you think about the generalizability to the typical cystectomy patient you might see in an academic center with multiple prior surgeries, perhaps prior radiation, perhaps, other things, those were not included in that trial. Yes.
Great talk, Cheryl. I was thinking about two patients that one I shared with Dr. Carroll and one I shared with Dr. Porton over the years. And, the one patient was a much earlier patient, and they both asked the same question, though, which was, well, if I don't get my bladder out now, and of course I'm a prostate kidney guy, so I don't know anybody, I don't have any answers. But they asked the question, if I don't get my bladder out now, if I just hold out for hope, will something better happen to me in the future? And can I just bide my time? And the earlier patient, he kind of held out for hope and got metastatic cancer and died eventually. And the more recent patient, I think what's exciting about urothelial cancer right now is there's a lot of change, a lot of great trials out. How do you think about that right now when patients approach you with that type of question, today's day and age?
Yeah, I mean, it's a great question, because this is what happened with these two patients, and especially the second one. He poses this to me every time I see him. What's new? Did that other drug, is it available yet? He's already anticipating that he's going to have a recurrence and is going to need that. And he knows that we've opened, that we're trying to get also into that pretzel study with Durafitinib. So he's already, I think, psychologically wedded to the fact that he is going to be continuously treated. He's very willing to use novel agents, and he's very committed to bladder preservation. And because I've been asking him to get his bladder out, to remove his bladder for years, and he's seen that actually he's done well without doing that, I think I've lost all credibility in that space. So I'm going to continue to support him and continue to make sure we have access to other options for him. But at some point, I suspect we'll run out of room. But as I think about that question, earlier versus later, we remember all of the retrospective data, of course, thinking about survival differences in patients who present with muscle invasive disease de novo versus progress to muscle invasive disease, over time. And the people who progress over time had worse outcomes, have worse survival. And I believe it's because we're watching them, and they're progressing right in front of us. And we're, I don't know if we become acclimated to this kind of situation that I'm in with this other patient. We check imaging periodically, and, we recur, and we, before you know it, though, at some point, we're going to check imaging and he's going to have, enlarged pelvic nodes.
What's your thoughts on trimodal therapy for T1 disease?
Yeah, there's there's a fair amount of data in Europe that there are benefits, survival advantages, certainly recurrence-free survival advantages for radiation for T1 disease. The RTOG had a study too, looking at that here, but it didn't accrue very well. Surprise, surprise. So I still think we do very well with T1 disease with radical resection and restaging as needed. The rates of of distant recurrence or even nodal disease are in the single digits. So I think part of failure pushes you to alter your treatment paradigm, and I do think there's morbidity and cost to radiation as well. So we have to consider those aspects. So I also don't see that becoming standard, although they've been doing, using that for T1 disease in Europe for years.
For these patients who have repeat TURBTs, what kind of data can you point them to in terms of what kind of urinary symptoms they might experience? Because I imagine someone who's had 5, 6, 7 TURBTs in the long term, their urinary function might decrease, or do you see that it kind of remains okay?
Well, that's interesting. And I can point to any colleagues in the audience that if you know that data specifically, but I mean, we have a lot of settings where people are treated in some of the trials, even we've been talking about, that are heavily pretreated with multiple TURs, multiple intravesical agents, and still maintaining good quality of life. And some of the data, even some of the European data, looking at EORTC data, looking at the timing of maintenance therapy, comparing groups of various strengths of BCG, full dose over 3 years versus a third the dose over 3 years versus a third the dose over 1 year. So you'd expect those patients, many of those patients did have recurrences and are subjected to long-term intravesical agents of BCG, and they actually did get quality of life data and in a very robust way. And there was no difference actually in quality of life outcomes and or toxicity in any of those 3 groups, which for, historically, we felt that patients on maintenance BCG, particularly those who made it to 3 years, had compromised, compromised voiding pattern, or had a great deal of intolerance and couldn't get to complete therapy. In the original studies from SWOG with the maintenance BCG, I think that it was about 17%, something like that, of the patients that actually completed full dose therapy for 3 years. So we felt like, look, there's a lot of intolerance going on. We're losing people in the pipeline, but that wasn't the experience over time. Now we've gotten smarter too, with reduced doses, with oral agents, and even some antibiotic therapies to help improve tolerance.
Sure, in my experience, if you get them through the toxicity of intravesical treatment, and over time, it gets actually better. You get them through the intravesical therapy. It's not so much the TUR, but the intravesical therapy. So I've seen a lot of patients have a lot of trouble for the first 2 years, and then you see them get through that at 5, 6, 7 years. They actually get better.
I agree with that. I mean, the only patients that I had that became bladder cripples were usually related to mitomycin and had either a perf with, I remember taking care of a couple patients who had been perf and then came to me and had just really debilitating and crippling bladder symptoms that required cystectomy.
Well, we thank you.